presented by our final year postgraduate student from RML Hospital, Dr. Kartika. Over to you, ma'am, for the proceedings of the session.
We should have to start, ma'am.
Yes, Kartika.
Good morning, everyone. 26-year-old female, Pinky, coming from Shadra. She's a homemaker by occupation. Her educational qualification is 6th standard. Patient came to casualty with chief complaints of history of amenorrhea for 36 weeks and decreased fetal movement since 1 day. History of presenting illness. Patient came with 36 weeks of amenorrhea and decreased fetal movement since 1 day. Patient was apparently normal 2 months back when she noticed EC fatiguability. This was insidious in onset, progressively increasing in intensity, aggravated by physical activities and relieved by taking rest. Associated with shortness of breath since 2 months, insidious in onset, was initially present while climbing 2 flights of stairs, progressively increasing in intensity. Now it is aggravated by doing household chores like washing clothes and mopping the floor and relieved by taking rest. Associated with palpitation since 2 months, insidious in onset, which is aggravated on exertion and relieved by taking rest. Swelling in both legs since 2 months, aggravated on prolonged standing and decreased with rest of foot and elevation. It is not associated with chest pain, breathlessness while lying down or sleeping, not associated with swelling of face, hands or decreased urine output, no history of loss of consciousness, no history of cough with expectation of blood in sputum or any seasonal variations of cough, no history of fever with chills or rigor, no history of headache or blurring of vision, no history of blood in urine, burning micturition or blood in vomitus, blood in stool, black color stools or bleeding PR, no history of passing worms in stool, no history of yellowish discoloration of skin or eye, no history of bleeding or leaking PD. Past history, no history of similar complaints in the past.
Kartika, can we stop here and
Yes, ma'am.
move back to the first slide where you were showing us the history of presenting illness? No, the slide previous to this.
Yes, ma'am.
Another slide previous to this. Yes. Okay, so here we have, you have just described that the patient's main complaints were the medical complaints. We're talking only about the medical complaints. So can you tell us what are the main medical complaints? Are you able to hear me? Neha, are you able to hear me?
Yes, ma'am, I am.
Has Kartika logged out?
Kartika. Ma'am, I guess there's some technical issue.
No, this is the first slide.
Shortly resolving it.
Okay, no problem. Welcome back, Kartika.
Kartika, can you hear, ma'am? Just unmute yourself, Kartika.
Yes, ma'am.
Yeah.
Sorry, ma'am, I can't hear your video.
Can you hear me, Kartika?
Yes, ma'am. What is the question, ma'am?
Yes, the question is, show me the next slide, please.
Yes, ma'am.
Okay, so you've told us the patient has easy fatigability. She has shortness of breath. Next slide. She has palpitations and she has bilateral edema, pedal edema. Correct?
Yes.
So
Yes,
when you
ma'am.
show us the next slide to this, you have something in mind why you're ruling out all these things, no?
Yes, ma'am.
So can you explain it line by line why you're ruling out all these things? Yes, not associated with chest
Ma'am.
pain, breathlessness. Yes.
Ma'am, the patient is not giving a history of chest pain or orthopnea or paroxysmal nocturnal dyspnea. I am ruling out congestive cardiac failure or any ischemic heart disease, which has been, and then swelling of face, hands, and decreased urine output. I am ruling out any kidney failure, renal failure, and no history of any loss of consciousness. I am ruling out a transient ischemic attack, and no history of.
Why are TIA is associated with the four symptoms that you've just told us?
Sorry, ma'am.
Why are TIAs, transient ischemic attacks, associated with?
Ma'am, if the patient is having any heart diseases and maybe due to embolization, there will be a transient ischemic attack for a period
Okay.
of time. So I am ruling out that. And no history of cough with expectation, blood and sputum, seasonal variation. I am ruling out the respiratory cause of breathlessness.
Okay.
No history of fever with chills or ague. I am ruling out any infections like malaria, dengue, or urinary tract infections.
Which can lead to?
Which can lead to parasitic infection like malaria can lead to anemia or UTA. UTA recurrent UTA can cause chorioamnionitis and preterm labor.
Why is this related to the four symptoms that we are bothered with?
Ma'am, malaria is associated with anemia, ma'am.
Okay, malaria is associated with
Associated with
anemia.
anemia.
Okay, so here now you're supposed to take a long history, because if you want to associate malaria with anemia, which is one of your diagnoses in your mind, then it has to be a prolonged history of or a history which is not very recent.
Okay, ma'am.
Okay. Next.
Then no history of headache or blurring of vision. I am ruling out preeclampsia.
Okay.
Blood and urine burning duration, maybe there will be a microscopic or frank hematuria, which might lead to anemia.
Anemia, and also it may be related to one of your other diagnoses, which is associated renal
renal function
disorders.
renal.
Okay, next.
And uh, there's no history of blood in vomitus or in stool, black color stools or bleeding PR.
Okay.
So I'm ruling out the chronic blood loss.
Chronic blood loss. Okay.
Blood loss. And no history of passing worms in stool. I'm ruling out the worm infestation, which might lead to anemia.
Okay.
And no history of LOS discoloration of skin or eye. I am ruling out jaundice, which can happen in hemolytic anemias.
Okay, good.
And no history of bleeding PV or leaking PV. Bleeding PV is which can lead to acute anemia.
Okay.
There's no history of bleeding PV.
Okay. Okay. So we can move on to the next slide now.
Past history. No history of similar complaints in the past, and no history suggestive of hypertension, diabetes, tuberculosis, bronchial asthma, seizure, thyroid disorders. No history of jaundice or repeated blood transfusion, and no history of previous surgeries.
Okay, so why do you want to take history of hypertension, diabetes, tuberculosis?
We have to know whether there is an associated chronic illness.
Okay,
patient, associated medical illness.
Okay.
And there has been no history of jaundice or repeated blood transfusion in the patient.
Okay.
So we are ruling out any genetic hemoglobinopathies.
Okay.
And there has been no history of previous surgeries.
And why is previous surgery is important here?
Ma'am, in case of gastrectomy or gastroduodenectomy, there can be an impaired absorption of iron that might lead to iron deficiency anemia.
All right. And multiple surgeries, if she has had multiple surgeries, that itself can lead to anemia.
Cause of anemia.
Okay. Next slide.
Obstetric history. Her last menstrual period was 8 March 2022 and expected date of delivery is 13th December 2022. First trimester, there's been no history of radiation exposure, drug intake or fever with rashes, no history of bleeding, PV or UTI, and history of irregular intake of folic acid tablet was present. Second trimester, quickening felt at 18 weeks, immunized with TT vaccine. History of irregular intake of iron, folic acid, and calcium tablets was present. No history of bleeding or leaking PV. No history of gestational hypertension, gestational diabetes, or gestational hypothyroidism. Third trimester, fetal movement perception was normal. No history of bleeding or leaking PV, abdominal pain, irregular intake of iron, folic acid, and calcium tablets. And in third trimester, she felt breathlessness and fatiguability and palpitation. Obstetric history. She's a gravida 3, para 2, and live 2. First pregnancy was full term normal vaginal delivery, 4 years. She's a girl child. Second pregnancy, full term normal vaginal delivery, boy child of 1.5 years. Irregular antenatal checkup and iron folic acid tablet intake in both pregnancies was present. Menstrual history. Her last menstrual period was 8 March 2022, menarche at 15 years, regular cycles 28 to 30 days, and 5 to 6 days of flow. No history of passage of clots or excessive bleeding. Marital history, married since 5 years, and it's a non-consenting. Family history, no history of chronic illnesses like hypertension, diabetes, tuberculosis, heart disease, jaundice, or any history of blood transfusion or any congenital abnormalities in the siblings.
Okay, so again, like we did for the presenting illness, can you explain why you're taking all these histories? What is the relevance of all these histories pertaining to the diagnosis that you have in mind or pertaining to the patient symptoms?
Yes, ma'am. I'm ruling out the chronic illnesses in the family.
Okay.
And heart diseases. Patient also has the symptoms of shortness of breath, palpitation. I'm just ruling out the heart disease if any heart disease running in the family, and family history of any hemoglobinopathies like sickle cell anemia or thalassemia, which might lead to jaundice and repeated blood transfusion, and congenital abnormalities due to vitamin deficiency. There may be a congenital abnormalities in the siblings, so there was no congenital abnormalities noted in the
Which
siblings.
congenital abnormality are you interested in?
Ma'am, folic acid deficiency, which might lead to neural tube defects, spina bifida or cleft palate.
So why is that familially related to your patient?
Ma'am, I'm asking for the siblings, ma'am, the previous child.
In the siblings,
Siblings.
then you say in not in the siblings, in the previous
pregnancies.
her own children, you mean to say?
Yes, ma'am. Sorry.
Okay, so can you move back a slide and give us a detailed this thing about all these histories also and how are they important? Move back a slide. Yes. What about the menstrual histories? Why is this? Okay, we can start from here. Past history.
Ma'am, she's a gravida 3, para 2, and live 2. She's multi-gravida, ma'am. This also contribute to anemia because of multiple births and prolonged period of lactation. And when we see the pregnancies, first, second pregnancy, and she's a third time pregnant, and there has been decreased spacing between. So this is the
Decreased
cause of
spacing
anemia.
between the, yes, very good.
And when we see the previous pregnancy, there has been an irregular antenatal checkup and irregular intake of iron folic acid tablet. So her stores might be low for this pregnancy.
Making your diagnosis move towards anemia.
Yes, ma'am.
Okay, next slide.
Ma'am, menstrual history, she has a regular cycles and 5 to 6 days of flow. So I'm just ruling out if there is any extra flows like menorrhagia, polymenorrhea, uh, or history
Okay,
of
which
passage
can
of.
be cause of anemia. Okay.
Then she's married, marital history, ma'am. She's married and non-consanguineous marriage.
Why is non-consanguineous important?
Ma'am, in consanguinity, there will be conditions, genetic hemoglobinopathies, which might be there,
Like
like thalassemia, sickle cell anemia,
thalassemia. Very
hereditary
important. Thalassemia.
spinocytosis.
Yes. Okay. Okay. So we can move on now?
Yes, ma'am. She has mixed diet, normal bowel and bladder habits, no history of any addiction or allergies. She belongs to a socio-economic status of lower class, 4% scale.
Okay.
General examination. Can I move on to general examination?
Okay. So when we are at the history itself, Kartika, we are supposed to, you've already, decided that the patient has anemia. Okay. So instead of focusing on trying to find out if it is because of a cardiovascular disease or respiratory disease or any other renal pathology, we will focus only on anemia. So in the history itself, what is important for us to know? Keeping the diagnosis of anemia in our mind, what is important when we do a PAC for any patient, when we do a PAC, what is important for us to know in the history?
We have to focus on the symptoms.
Symptoms, you have excellently covered all the symptoms. But you, as a physician who's going to give anesthesia to the patient, what is important for us to know? We want to know what is the cause of the disease that she is having. Is it important for this and for anemia? Why do we want to know the cause of the anemia?
Ma'am, we have to find out the cause, whether it is due to nutritional deficiency or due to any chronic disease or due to
Very
any
good.
acute hemorrhage, or maybe due
Acute
to
or
genetic
chronic hemorrhage, or which may be related to coagulopathies. Okay.
coagulopathies.
So, which is a very important thing for us as an anesthetist. We should know whether the patient has a coagulopathy or not. You're going to decide about your decision about anesthesia will come from that knowledge.
Yes, ma'am.
So you want to know the cause of the anemia, and you will, in your history, you will ask all these leading questions, which will tell you about the cause of the anemia. Okay. So you've already discussed all that. What else is important?
Examination.
No, not in examination, in the history itself. For any disease, for a patient who comes with, say, a disease which is called XYZ, you want to know as an anesthetist what is the cause of the disease, if the disease has multiple, pathophysiologies. Second thing, you want to know what is the severity of the disease. Okay.
Yes,
and the third thing, you want to know whether the patient is on any optimization for that disease.
yes, ma'am.
Okay. So what is the severity of the disease according to your symptoms the patient seems to be?
She seems to be severely anemic, ma'am.
Severely anemic because she's having a lot of symptoms which point towards
severe anemia.
Severe anemia, yes. What can be the complications of anemia? The other thing that you want to find out is whether that disease that the patient has, XYZ disease, is leading to any complications. So what are the complications of anemia that you want to rule out in your history itself?
Ma'am, I want to know the patient is compensated or not. From the
Compensated
history,
or
the
not?
patient.
Excellent. Very good. Why?
Ma'am,
So what kind of decompensation can she be having because of anemia?
Ma'am, she might have cardiac decompensation. In severe
Right.
anemia. she will end up in cardiac failure, congestive cardiac failure, ma'am. From
Congestive
the
cardiac
history,
failure. So in the history itself, you were asking about what specific history have you asked, which will suggest patient has
ma'am,
cardiac failure?
chest pain, breathlessness while lying down, orthopnea, or paroxysmal nocturnal dyspnea. She's not having any of the symptoms, ma'am.
Okay, very good. And cough, she
And
may have that kind of a cough, which she's not having. So all those things will point towards a congestive cardiac
congestive
failure.
cardiac failure.
Okay, so this is how you want to rule out. This is how you want to conduct your history. You want to
Yes.
rule out what are the complications of anemia that you need to look out for. And now when we move on to examination, we will keep all these things in mind. You want to keep in mind what is the cause of this anemia, what is the level of severity that she has, what is the what is the complication that she's having because of anemia. Okay.
Okay.
Move on.
General examination. After getting informed consent, patient was examined. She was lying comfortably on bed in left lateral position, alert, conscious, cooperative, and oriented to time, place, and person. She was thin built and poorly nourished. Height was 152 centimeter, weight 53 kgs, and BMI was 19.9. Pre-pregnant weight was 46 kgs, and weight gain in this present pregnancy is 7 kgs. On examination, she had severe pallor, bilateral pitting pedal edema, smooth tongue, pale nails, and vertical ridges in the nails. No ictus, cyanosis, clubbing, or lymphadenopathy, and JVP was not raised.
Okay, so can you tell us why you have asked about icterus, cyanosis, clubbing, and is there anything else in the nails that you need to look for? Vertical ridges you've already told us.
Vertical ridges, coelonychia can be seen in anemia, ma'am. And there's cyanosis and all not there. I am ruling out jaundice and many
What about
heart disease.
other causes of anemia, say anemias like thalassemia or
Yes, ma'am.
megaloblastic anemia? Will they have some different examination findings?
In megaloblastic anemia, there might be angular stomatitis, glossitis,
Angulostomatitis, very good, yes.
glossitis,
Glossitis, very typically seen in megaloblastic anemia. And
megaloblastic
what
anemia.
about thalassemia?
Thalassemia, there will be frontal bossing and malar prominence due to ineffective erythropoiesis, and patient give the history of repeated blood transfusion and jaundice.
So, yes. Okay. And what about coagulation deficiencies? Anything in examination that is important?
Ma'am, in coagulation deficiencies, there after injury, there's prolonged bleeding episodes.
Right. Examination.
Examination.
Any petechiae, bruise.
Bruises, rashes will be seen.
Okay. Okay. So what is next? Move on to the next slide.
Yes, ma'am. Vitals. Pulse rate was 110 beats per minute, regular in rhythm, normal in volume character. No radio, radial, or radiofemoral delay. All peripheral pulses felt bilaterally and were equal. Blood
What
pressure
is
was
an important finding in the character of the pulse in severe anemia?
Ma'am, in severe anemia, there will be high bounding pulse, ma'am.
High bounding pulse and
Due to hyperdynamic circulation and tachycardia.
And there is a wide pulse pressure.
Wide pulse pressure is ma'am.
Okay.
Yes, respiratory
What is
rate was
pulse pressure, Kartika?
ma'am, pulse
What do
pressure
we mean
is
by wide pulse pressure?
ma'am, wide pulse pressure is systolic blood pressure will be increased and diastolic will be at the normal range, leading to wide pulse pressure, ma'am.
Systolic will be increased.
Systolic BP will be increased and diastolic will be of normal range.
No. The difference between the systolic and the diastolic
Diastolic is
becomes
the blood pressure,
is
pulse
increased.
pressure. Yes, ma'am.
Okay. It's not related to systolic pressure or the diastolic. Only the difference is increased. Okay. So that is wide pulse pressure.
Yes, ma'am.
Okay. Move on.
Respiratory rate was 18 per minute and she was afebrile to touch. Airway examination, no obvious facial deformity was seen. Mouth opening was more than 5 centimeter. Modified Mallampati class was grade 2. Oral hygiene was good. No missing loose tooth or artificial dentures. Thyromental, hyomental, sternomental distance are of normal range. Neck circumference was 37 centimeter. Neck range of movements was full.
Okay.
Examination of back. There was exaggerated lumbar lordosis. Mild pitting sacral edema was seen. No skin infections, shoulder deformities, scar marks, visible venous pulsation, hyperemia of sinus. Abdominal examination. Inspection. Abdomen longitudinally distended, flanks not full, umbilicus everted. All quadrants move equally with respiration. Stria gravidarum and linea nigra was seen. No dilated veins, scars, or sinuses. Palpation was done in like semi-flexed position. Fundal height correspond to 32 weeks and there's no hepatosplenomegaly. Auscultation, fetal heart rate of 100 per minute heard over the left spino-umbilical line. Cardiovascular system. Inspection, shape of precordium was normal. No precordial bulge, visible pulsation or engorged veins. No scars, sinus or pigmentation. Apical impulse was not seen. Palpation. Findings of inspection were confirmed. Apex beat left was felt at left fourth intercostal space, lateral to mid-clavicular line. No parasternal heave, thrill or pulsation in any area. Auscultation. S1, S2 are normal. Ejection systolic murmur of grade 3/6 heard in the aortic area.
Okay, so are there any other conditions which can have a ejection systolic murmur, which can have a wide pulse pressure?
Ma'am, in aortic stenosis, there will be ejection systolic murmur and wide pulse pressure. And,
What kind of a failure occurs in anemia?
Ma'am,
What-
high output.
High output
High
failure.
output.
Very good. So you know of any other condition which can lead to a high output failure?
HOCM.
HOCM will not lead to high output failure. Thyrotoxicosis,
Yes, ma'am, thyrotoxicosis,
sepsis.
sepsis.
What do we exactly mean by high output failure?
Ma'am, there will be increased cardiac output and increased venous return, and there has been a increased workload on the left ventricle, and leads to left ventricular hypertrophy.
So AV fistula.
Increased, yes, ma'am, AV fistula, and due to increased workload and venous return, the left ventricular hypertrophy will be seen, and there will be a inadequate contractions leads to failure.
Not all high output failures will be associated with left ventricular hypertrophy, especially those associated with anemia.
Yes, ma'am.
Okay, hypertrophy only occurs when there is resistance to the ejection of the heart. Okay, when the ventricle is acting against a very high resistance, then only the hypertrophy will be seen. In anemia, thyrotoxicosis, you will not see a hypertrophy. Okay. I think Kartika is logged out again.
No, I'll just get it fixed.
No problem.
Kartika, can you hear us?
Yes, ma'am. There's been technical glitch. I'm sharing my screen. Yes, ma'am.
Okay, Kartika. So we were discussing high output failure. Okay.
Yes, ma'am.
Okay. So when you're doing the history and examination, you have to keep the differential diagnosis for high output failure also in mind. So whether the patient has thyrotoxicosis, whether the patient has, she's of course, if she had a AV fistula, it would be very obvious. Okay.
Okay.
So she does not seem to be having all those things. Okay. Okay.
Yes, ma'am.
Similarly, the same findings of having a systolic, it's typically a mid-systolic murmur and the grade would not be very high. and the patient would be warm, will have warm extremities, will have
Yes.
slight tachycardia, can be seen in thyrotoxicosis also. Okay.
Yes, ma'am.
We'll move on.
Yes, ma'am. Respiratory system inspection, trachea appears to be in the midline. Chest normal in shape, size, and bilaterally symmetrical. No chest wall deformities visible. Dilatation of veins, swelling, or supracavular bulge. Palpation. Findings of inspection were confirmed. No vocal phlegmatus present. Auscultation. Bilateral normal vesicular breath sound heard. No added sound, and vocal resonance was normal. Central nervous system, higher mental functions normal, cranial nerves intact, motor normal in tone, power, no atrophy or abnormal movements, sensory functions and reflexes were normal.
So here again, what are you trying to focus on in the central nervous system? See, we can just rattle off all these findings and without, for all cases that we, kind of discuss, okay? But that doesn't serve the purpose. Even in the respiratory system, what is your focus on?
Ma'am, respiratory system, just a normal systemic examination. And there's
Yes,
been
but
no
you have to
findings.
focus on something pertaining to your case. We said we're going to focus on trying to find the cause of anemia. You're going to focus on the severity of anemia.
Severity of
You're going to
anemia.
focus on the complications related to anemia.
Complications.
Correct? So pertaining to all these three, how important is the respiratory system examination? What are you trying to find out? Can any
Ma'am, in
causes,
respiratory,
yes, be related to respiratory system? She could have a
ma'am, increased, ma'am, she might have increased respiratory rate and increased minute volume.
okay, so that all those are compensations for
Yeah,
anemia.
yes, ma'am.
What
Yes,
about the causes of anemia? Any of the causes you can think of? You rattled off so many causes of anemia. What about chronic disease? Any of the chronic disease? You said in the history, no history of tuberculosis, no history of tuberculosis, no history of bronchial asthma. And in all throughout the history, we have been focusing on tuberculosis. Now you want to corroborate that history to the examination, correct?
Yes, ma'am.
You have to, you don't have to, I mean, we can all remember all these things and rattle it off in the exam. But when actually giving anesthesia to a patient, you have to remember all those things here. Okay?
Yes.
Okay, so
And
how
there's been no findings
yes, in inspection,
related
it
to
is very
tuberculosis.
important. Huh? Similarly,
Tuberculosis or asthma
yes,
or any chronic causes like carcinoma has been
okay,
ruled
very
out in
good.
these exams.
Anything else? So you want to see whether the any of the sequelae of tuberculosis are seen on inspection, or you can on auscultation. Can you have bronchial breath sounds which would be related to fibrosis? Do they have findings suggestive of bronchiectasis? Do they have findings suggestive of? And what are the complications that you're looking for? Yes.
Chronic
Do they
bronchitis.
have? Okay.
Yes,
So
ma'am.
that is why your examination is going to be helpful. Your examination is not going to be helpful like this if you rattle off all the things without actually, focusing on your patient. Okay, you have to focus your findings according to your patient. Okay.
Yes, yes, ma'am.
Okay. So what about auscultation? What about why are we when you auscultate a patient with severe anemia? What are you auscultating for in terms of complications?
Ma'am, auscultation, we can find a functional murmur.
No, respiratory system auscultation.
Respiratory system. Ma'am, we hear a normal vesicular breath sounds and
She had, but why did you even auscultate?
Ma'am, to see if there is any associated crepes. In
Right,
case of
correct. Which will,
pulmonary edema, in
yes,
case of
very
pulmonary
good.
edema, we can hear
Yes,
basal crepe.
yes. She has breathlessness. She has history suggestive of a high output failure. A lot of other features in the history and general physical examination are pointing towards high output failure. So you want to corroborate all those to your auscultatory findings. Okay.
Yes, yes, ma'am.
Okay. Next. Now, what is important here? Can you correlate all these findings to your Cause of anemia, severity of anemia.
Ma'am, in central nervous system, I am checking the sensory function or in folate deficiencies and vitamin B12
Very
deficiencies.
good.
That
Yes. So what is the
yes.
anesthetic implication if she has folate deficiency?
Ma'am, in folate and vitamin B12 deficiency, there will be a demyelination of spinal cord. There will be a subacute degeneration of spinal cord. So while giving spinal, it will attenuate the demyelination, ma'am.
You have to,
So
yes.
we
Then
have to be careful in
giving
while
spinal,
giving
giving
spinal
regional anesthesia becomes a concern for you if she already has existing peripheral neuropathies.
neuropathies.
So peripheral neuropathies are a common association with megaloblastic anemia.
Neoplastic anemia.
Okay. So you're understanding now why CNS examination is important. Otherwise,
Yes,
why
ma'am.
would you look at a patient? You're not going to do all the examinations for all the PSCs that come now. But when you do an examination, you have to keep that diagnosis in mind and correlate it according to your provisional diagnosis. Okay.
Yes, ma'am.
Next slide.
Summary. 26-year-old female, gravida 3, para 2, live 2, with a period of gestation 36 weeks, came with complaints of decreased fetal movement since 1 day, which was associated with AC fatigability, dyspnea on exertion, palpitation, swelling in both legs. On examination, she was found to be pale. Pale nails was present, smooth tongue, and vertical ridges in the nails was present. Bilateral mild pitting pedal edema, ejection systolic murmur in the aortic area, and fetal heart rate of 100 beats per minute.
Okay. What else is important in summary for you?
Ma'am, all the positive findings, the symptoms she is having, the examination findings, and
Her own vitals are also important. Okay.
okay, ma'am.
Okay. Next, you've made a provisional diagnosis.
Yes. Provisional diagnosis: a 26-year-old female, gravida 3, para 2, live 2, with 36 weeks of period of gestation, with severe anemia complicating pregnancy, probably due to nutritional deficiency, with fetal distress, posted for emergency LSCS.
Okay. Why is she posted for emergency LSCS? What kind of an emergency is this?
Ma'am, she has a fetal heart rate of 100 beats per minute. Ma'am, she is the fetus is having a bradycardia on monitoring, fetal heart monitoring, ma'am. So that's why she's posted for emergency LSCS. This emergency grade 1 emergency
Category 1.
category.
Can you tell us the other categories for cesarean sections?
Yes, ma'am. There are 4 grades, ma'am. Grade 1 is emergency, which is immediate life threatening to mother and fetus. Grade 2 is urgent.
Category. Urgent.
Urgent is it is not life threatening, but a fetal compromise to mother and fetus. And third is scheduled. Scheduled is needs early delivery, but there is no fetal or maternal compromise. And grade 4 is elective. Elective, it can be done suitable for the woman or maternity team.
Okay. So the fact that she is a category 1 cesarean section has been documented in the patient's file, has been documented by the obstetricians who are taking care of the patient. They said it's a category 1 cesarean section. Okay. So how do you want to proceed? You want to do any investigations? Should we discuss the investigations first? Neha, this is the complete time that we're going to finish the case discussion in 30 minutes. Or do we have to leave some time for the discussion later on?
Ma'am, 15 minutes for my summary.
Okay.
And any questions after that. So maybe 20 minutes we can leave in the end, including my time and the question answer session.
Okay, no, but this clock says 29 minutes. So how long can I continue with the Kartika?
Ma'am, 10 minutes more maybe.
10 more minutes. Okay, Kartika, so quickly we'll go through the investigations that you would like to see for this patient.
For this patient, since it is an emergency section, I'll ask for hemoglobin, and I'll make sure the blood has been sent for blood grouping and cross matching, and I'll make sure the blood has been arranged for the intra-op period, ma'am.
Okay. So investigations, you've seen the hemoglobin. You want to see the hematocrit?
Hematocrit, yes, ma'am.
What is the
Hemoglobin.
difference between hemoglobin and hematocrit? What values will they tell you differently?
Ma'am, hematocrit is a red cell mass, ma'am. So if the hematocrit is less than 22, it's telling that red cell mass is less in the patient.
Yes, but you can get the same. Why is it separate from hemoglobin? Why do you get a different value of hematocrit? And how do you want to correlate it?
Ma'am,
If the
RBC,
hemoglobin is 7, the hematocrit value would be 21. What are the, in other words, what are the conditions where hemoglobin and hematocrit may not match like this? And it would be important for you.
ma'am, it implies the oxygen carrying capacity of
No,
the
no,
red.
no. In conditions where the red cell mass will be more, hemoglobin is a value which comes through an electronic counter. Okay,
Yes,
and the hematocrit is an actual volume of the RBCs.
red blood.
Okay, so that is calculated separate differently. It only kind of calculates the volume of the RBCs. So which are the conditions where the volume of the RBCs is more, but the hemoglobin may be low? Any kind of anemia?
Ma'am, macrocytic anemia.
Macrocytic anemia, very good. Okay.
Yes,
So
ma'am.
megaloblastic anemia, the hematocrit value would be normal, maybe normal, but your hemoglobin would be low. Okay. So that is one thing that you are interested in when you're looking at the complete blood picture. Okay. So this patient has a hemoglobin of, you've seen the investigations for this patient?
As per the investigations, she has a hemoglobin of 6 and
Okay.
a total leukocyte count of 8,400, platelet of 2 lakhs, and random blood sugar was 104.
So essentially all other investigations are normal and
So
she only
normal
has a hemoglobin of
is the
6 gram percent. So how do you want to proceed for anesthesia?
Ma'am, I would like to, since it's an emergency section and the hemoglobin also 6, I would like to give general anesthesia for this patient.
Okay, so can you enumerate why general anesthesia is beneficial?
Ma'am, in our case, the patient is the fetus is in distress and it is an emergency cesarean section. And
You
the
do
patient
not have an
hemoglobin is
option.
also,
Hmm.
yes, ma'am.
But
And the patient,
if given a choice, why?
yes, ma'am.
What would you like to do, and what would you like to do differently than a patient who's come for an elective cesarean with normal hemoglobin?
Ma'am, for elective LSCS, I'll go with subarachnoid block, ma'am. And
No, we're going to give general anesthesia to this patient who's severely anemic.
yes, ma'am.
Okay. So how would
Yes,
your
ma'am.
anesthetic management be different than a patient who's come for elective cesarean section?
Yes, ma'am. In the hemoglobin of 6, I like to proceed with general anesthesia with the RSI, rapid sequence induction. And ma'am,
What are you going to do differently than a normal patient, than a
ma'am,
normal cesarean section?
yes, ma'am, I'll do a titrated induction to maintain the hemodynamic stability.
Okay, very good.
And ma'am, I'll avoid hypoxia and I'll
Hypoxia we
avoid.
are going to avoid in all the patients, Kartika. I
Yes,
see
ma'am.
hypoxia, but what is important for you here is to remember that the oxygen delivery is very
Delivery
much
should,
dependent on
yes, ma'am.
cardiac output. Okay,
Cardiac
so it
output.
is
I'll maintain.
important. It is extremely important to use drugs which are cardiostable. So, what are you going to use for induction agent as your induction
Ma'am,
agent?
yes, ma'am, I'll use injection etomidate 0.2 to 0.6 mg per kg
0.2,
in the
0.6
tight,
mg per kg. Okay.
and I'll do RSI, ma'am, with the required pressure, and I'll give injection Scolin 1.5 mg per kg,
And you will
and
ensure, what about free oxygenation?
Yes, ma'am. Pre-oxygenation has been done till the expiry O2 will be more than 90%.
You will
And I'll
ensure, yes, you will ensure that it is perfectly done. You will come to the
yes,
patient
ma'am.
and then ensure that it is perfectly done. It is important for this patient because any amount, she is not going to tolerate any amount of decrease in oxygen delivery.
Decrease in oxygen. Yes, ma'am.
Okay, next.
And I'll induce with etomidate and scolan, and after giving scolan, after 45 to 60 seconds, I'll intubate the patient with endotracheal tube of 7 mm of internal diameter. And after securing the tube, I'll put the patient in 100% oxygen and CO of 1.5 percentage. And I'll throughout the procedure, I'll maintain hemodynamic stability, and I'll maintain cardiac output.
You're not giving any analgesia. You don't want to use nitrous oxide.
Ma'am, already the fetus is in distress, ma'am. So till the delivery of the baby, I like to give 100% oxygen to the mother,
I
and after
don't
that,
think that is necessary, Katia. I think 50% oxygen is enough for the fetus. The fetus is only going to get the oxygen which is going to cross
going to
the
cross placenta.
placenta. Okay. And this analgesia is important for the mother. Why is it important? You're not giving any analgesia for a cesarean
Yes,
section.
ma'am.
Why is
Ma'am,
it
I'll,
important? Hmm?
ma'am, pain it will
Lead to a lot of tachycardia.
tachycardia, and it will increase oxygen consumption.
She is already on the verge of decompensation, you know.
Yes,
Okay.
ma'am.
So what
Yes,
are
ma'am.
your goals when the patient is anemic? What are your goals? You don't want to increase in
Is
the
any pain, fever, or I'll avoid any shivering.
right
I'll
and
maintain the temperature.
temperature. Excellent. Because all these things are going to do what?
All these things will shift the oxyhemoglobin dissociation curve to the left, so which results in
Remember all
inline
these things as
deoxygenation
so they are going to increase the oxygen demand for the patient and
demand,
decrease the oxygen delivery to the tissue.
oxygen delivery.
Okay,
Yes,
so
ma'am.
now do you want to give some nitrous oxide to the patient?
Yes, ma'am. I will give switch over to 50% oxygen, 50% nitrous oxide,
Nitrous.
and
Okay, then
side by side I'll give paracetamol also 15 mg per kg IV. And after the delivery of the baby, I'll give oxytocin, and I'll replace blood for blood. I won't give liberal fluids, ma'am. I'll watch for pulmonary edema also, and signs of congestive cardiac failure.
you want to transfuse this patient?
Yes, ma'am. I would like to transfuse once the hemostasis is achieved. I would like to transfuse packed RBCs. And after the delivery of the baby, I'll give fentanyl 2 mics per kg.
You will start with fentanyl 2 micrograms per
2
kg
mics.
and you will titrate it to effect. Okay. So you remember all the alterations in the pharmacokinetics that will happen with anemia?
Yes, ma'am. I mean, anemia, there will be a increased sympathetic drive. It will lead to increased heart rate, increased cardiac output, and increase in 2,3 DPG. This causes
The
the
pharmacokinetics for all the anesthetic drugs. How will they change?
yes, ma'am. I mean, anemia, the pharmacokinetics will be increased due to the hemodilution and decreased enzymes in the plasma.
Okay. What else? What happens to the volume of distribution? What happens to the plasma protein binding?
Yes, ma'am. The volume of distribution will be increased in anemia, ma'am, and the protein binding will also be protein binding is decreased due to the hypoalbuminemia, and concentration of drug in the plasma will be increased, and it leads to reduced clearance.
So what
Reduced clearance.
happens to the duration of action? What happens to the bolus dose?
Ma'am, duration of action will be increased in anemia patients, and
And
we have to rate according to the effects, ma'am.
the bolus dose, what happens to the bolus dose?
It will be decreased.
Okay, so you cannot say just standard 2 microgram per kg of fentanyl. You have to titrate it to it.
Okay.
Neha, you can take over.
Okay, thank you so much, ma'am. Thank you so much, Dr. Karthika, for that exhaustive discussion on such an important topic. So I'll just like to summarize what all has already been discussed. So now let's begin with the WHO definition of anemia. As we all know, in non-pregnant females, the cutoff is 12 gram%. However, the cutoff is obviously lesser because of the physiological changes in pregnant females. In first and third trimester, if the female has a hemoglobin of less than 11 gram%, she is labeled as anemic, and the cutoff in second trimester is even lesser, that is 10.5 gram%. Now coming on to the severity of anemia, the ICMR categories divide anemia into mild, moderate, severe, and very severe categories. Mild anemia is labeled when HB is between 10 to 11 gram%, moderate is 7 to 10 gram%, severe, as in this case, it's less than 7 gram%, and very severe or decompensated is said when the HB is less than 4 gram%. Now, various criteria by which anemias can be classified is, firstly, is physiological anemia of pregnancy and pathological anemias, and then we can have a morphological classification as well. As you all know, physiological anemia of pregnancy is a dilutional type of anemia, since as the pregnancy progresses, the increase in plasma volume is much more than increase in RBC volume, eventually leading to a dilution. So this has certain advantages like enhanced placental perfusion and increase in volume in anticipation of blood loss during childbirth. In pathological anemias, we have nutritional anemias, which are commonest in our country in the form of iron and folate deficiency anemias. Hemorrhagic can be due to acute or chronic bleeding. Infections, malaria, and HIV are known to cause anemias. And in hemolytic anemias, we have sickle cell disease and thalassemias. Depending on the RBC morphology, anemias can be microcytic hypochromic, as in iron deficiency in thalassemia, normocytic normochromic, as in acute blood loss and hemolytic anemias, and macrocytic picture can be seen in folate deficiency and vitamin B12 deficiency. What are the various concerns that we need to take care of in an anemic patient? First, as ma'am discussed, the etiopathogenesis, what is the type of anemia? Then in case it's an acute blood loss, we need to know the rate of blood loss and the volume at which it is occurring. We need to decide on the transfusion trigger, that is the level of the hemoglobin at which we decide to transfuse blood to the patient. Then the core problem in anemic patient, as we all know, is tissue oxygenation. So what is the effect of anesthesia on this tissue oxygenation? And for that, we need to know, we should be aware of all the oxygen delivery definitions that are there, like oxygen content, which is the addition of the dissolved and bound oxygen in the blood, oxygen delivery, that is oxygen content into cardiac output, and lastly, oxygen consumption, which is the difference of the arterial and venous oxygen content of the blood into cardiac output. So you all should be aware of all these definitions. Now coming on to acute anemias, there are various compensatory mechanisms which occur due to acute blood loss, which is increased blood velocity, sympathetic stimulation leading to vasoconstriction and tachycardia. There's redistribution of blood flow to vital organs. There's water and electrolyte conservation. And there's a switch over to mainly anaerobic metabolism, eventually leading to lactic acidosis. So how to manage a patient presenting with antepartum hemorrhage or acute blood loss? One needs to secure wide bore cannulae. Then fluid resuscitation needs to be done. One needs to give supplemental oxygen. Blood needs to be drawn for complete blood counts, blood grouping and cross-matching. Blood needs to be arranged. Left uterine displacement, as you all know, has to be done to avoid further exacerbate the hypotension. Patient needs to be catheterized and given acid aspiration prophylaxis. Now, if the hematocrit is more than 25% and there's normovolemia, one does not usually need to transfuse blood. Blood needs to be transfused if HB falls to less than 7 gram% or if 7 gram% with an ongoing blood loss. The actual decision to transfuse blood depends on the actual blood loss which is happening, the physical status, that is the vitals of the patient, and his compensatory abilities. If there's associated coagulopathy, then FFPs need to be transfused. Usually regional anesthesia is not indicated such cases, and the choice of anesthesia is general anesthesia with rapid sequence induction. The agents which can be used for RSI are thiopentone, etomidate, or ketamine. Inhalational agents, since they cause hypotension, need to be kept to minimum. One needs to maintain normocarbia, and a high FiO2 needs to be given. Tissue perfusion should be maintained with fluids and, if needed, inotropes. Monitoring includes your heart rate, ECG, NIBP, SpO2, EtCO2, urine output, ABG, and temperature. CVP can be considered. And post-operatively, oxygenation and ventilation needs to be maintained. A good post-op analgesia is needed. One needs to prevent any shivering or any rise of temperature, and blood transfusion if still required. Now, coming on to our topic, which was nutritional anemia. It's the most common type of anemia seen in our country, especially iron deficiency anemia, and there is associated folic acid and vitamin B12 deficiency as well. It's common because of the poor dietary iron intake and faulty dietary habits in our country. Also, the main reason is repeated pregnancies in short intervals, prolonged lactation, and also folic acid requirement increases during pregnancy. And our diet being deficient in vitamin B12 also plays a role. Now, you all should be aware of the iron requirement during pregnancy. So it's mainly 60 to 80 milligrams per day. Now, what are the diagnostic criteria of iron deficiency anemia? The blood indices: plasma iron of less than 30 microgram per deciliter, transferrin saturation of less than 15%, serum ferritin levels of less than 12, MCV of less than 75, MCH less than 25, and MCHC less than 30%. That is a picture of microcytic hypochromic anemia seen in iron deficiency. Coming on to folate deficiency. Folic acid, as you know, is a cofactor in nucleic acid synthesis. Its stores are already limited, and the daily requirement is around 300 to 500 micrograms per day. High incidence is seen in multigravida, twins, in hyperemesis gravidarum, and the patients with a history of alcohol consumption, smoking, or on any drugs. The fetal effects include neural tube defects, premature births, cleft palate, and the effect on mother includes a high abortion rate. So as we have seen in this case, the main history that needs to be taken is the dietary history of the patient, any history of any chronic bleeding, the occupational history of the patient, any medications that the patient is on, basically all the history related to cause of the anemia. Usually these patients do not present with these symptoms on their own, but on further probing, we come to know that the patient has had a history of fatigue, malaise, lassitude, loss of appetite. There is dyspnea on exertion, palpitations, postural hypotension, and in extreme decompensated cases, history suggestive of heart failure. On examination, the patient will show tachycardia, pallor, glossitis, koilonychia, edema, hepatosplenomegaly, lymphadenopathy. There will be a functional murmur and cardiomegaly in cases of CHF. So this is very important to know what are the compensatory mechanisms seen in chronic anemia patients. There's an increase in 2,3 DPG levels, shift of ODC is to the right. At the tissue level, there's an increased extraction ratio. There's an increase in erythropoietin release. Circulatory changes include decrease in viscosity, increased cardiac output, myocardial hypertrophy. Respiratory changes include a decrease in reserve, decreased physiological shunt in the lungs, and hyperventilation. And in GIT, there's decreased platelet blood flow. So basically, there's an attempt to increase the oxygen extraction for the vital organs. Complications of severe anemia during pregnancy. These patients are prone to preeclampsia, infections, heart failure, preterm labor. During labor, the patient can land up into uterine inertia, PPH, CHF shock. Postpartum sepsis, subinvolution, and failing lactation. On the fetal effects, there could be high incidence of low birth weight, prematurity, IUD, and hypertension during adulthood. Now, such chronically anemic patients, they require an adequate antenatal care. They need a high protein-rich diet. Iron folic acid supplementation should be given. And the mainstay, obviously, is iron therapy, either orally or parenterally. Now, coming on to the oral iron therapy, the most common preparation used is ferrous sulfate. The dose is 60 milligram of elemental iron thrice a week. The rate of increase of hemoglobin with oral therapy is around 1 to 1.5 grams per deciliter per week. Now, the main problem with oral therapy is non-compliance of the patients. The reason being it leading to a GIT upset. So in case there's failure to respond to oral therapy, intolerance or non-compliance, one needs to shift the patient over to a parenteral therapy. And the Government of India regime for oral iron therapy is 100 milligrams of iron with 500 mics folic acid during second half of pregnancy for 100 days. In parenteral therapy, the rate of rise with every 250 milligram of iron is 1 gram %. It's important to know that the rate of rise with oral and parenteral therapy both is 1 to 1.5 gram % per week. The only difference is the patients who are non-compliant to oral therapy, they need to be switched over to parenteral therapy. So the preparations available are iron dextran, iron sorbitol. IM injections are usually quite painful and cause staining. So the preferred route is a total dose IV infusion. The formula to calculate the dose is 0.3 into body weight into the 100 minus hemoglobin %, the weight being in pounds. And it's important to know that when the patient needs to be given parenteral iron, it should be in proper hospital settings with all the preparation for resuscitation ready, since anaphylaxis can occur. So all the resuscitation equipment, drugs, adrenaline, oxygen need to be kept ready. Now, when to transfuse blood in chronic anemias? If the pregnancy is less than 36 weeks, then the cutoff is 5 gram %. That is, if the patient has HB of less than or equal to 5 gram %, then the patient needs to be given blood. In case the HB is between 5 to 7 and the patient has features of CHF, hypoxia, infection, septicemia or heart disease, then again blood needs to be transfused. For pregnancy of period of gestation of more than 36 or equal to 36 weeks, the cutoff is 6. And if the HB is between 6 to 8 with all these features, then again blood needs to be given. Now, it's an exhaustive list of all the investigations that need to be done in chronic anemia. That is obviously in the setting of an elective cesarean section. So a complete blood count, including HB, TLC, DLC, peripheral smear. Blood grouping needs to be done. All the RBC indices need to be done. ECG, 2D echo, chest X-ray. Then stool and urine examination for the cause of anemia, serum proteins, and any other investigation for the primary cause. Then bone marrow examination for stainable iron. And in case an iron deficiency is suspected, all the iron studies, which include serum iron, iron binding capacity, ferritin assay, transferrin receptors, should be done. And concurrently, folate and vitamin B12 levels. In case hemolytic anemia is suspected, a whole hemolysis workup needs to be done. Now, coming on to the plan of anesthesia in chronic anemia. Regional anesthesia is considered safe if the HB is more than 8 gram % or 8 gram % with no cardiac decompensation. One needs to be very careful with preloading these patients because excessive preloading or very liberal preloading with crystalloids can exacerbate dilutional anemia and precipitate CHF. These patients are unable to compensate for the chemical sympathectomy related to regional anesthesia. In megaloblastic anemia, there's an additional factor of issue of neurological symptoms post-operatively. So if you're going for regional anesthesia, you need to give supplemental oxygen to the patients, and one needs to go for low-dose local anesthetics with opioids. Blood loss obviously needs to be monitored and replaced accordingly. The benefits of regional anesthesia is it leads to less blood loss and a good post-op analgesia. Now, when is general anesthesia the plan of anesthesia? If the HB is less than 8 gram % or 8 gram % with cardiac decompensation. Again, the goals are to maintain the cardiovascular stability, avoid any hypoxia or any causes which lead to leftward shift of ODC. One needs to adequately pre-oxygenate the patient, avoid any aortic cable compression. IV induction needs to be slow and blood replacement should be done adequately. These patients are quite prone to the myocardial depression effect of volatile agents. So these agents should be used in less concentration, which can lead to a possibility of awareness. Then one needs to avoid, again, hypothermia, alkalosis, and hypocapnia. All these are related to the leftward shift of ODC. One needs to monitor for complications, especially like CHF, and a need for post-op ventilation should be explained to the patient prior. Coming on to the post-op care in post-op chronic anemias. Patient needs to be shifted to a high dependency unit. Proper oxygenation needs to be maintained. One needs to prevent any shivering because it leads to increase in oxygen consumption. Any fever, if present, should be treated. A good post-op analgesia should be given, and the monitoring should continue. Patient should be given blood transfusion if needed. Thank you. I don't think there are any questions.
There are no questions as such.
Ma'am, anything more you would like to add? Anything that we might have missed?
No, I think we must have covered everything, Neha. But the regional anesthesia will provide some advantages in these patients in terms that the maintenance of the maintenance of tissue perfusion would be better preserved with regional anesthesia.
Yes.
Okay, so if unless the patient seems to be in a decompensated state, a patient with 6 gram% with breathlessness would probably not tolerate a regional anesthesia. It would be difficult for her to lie down also. So a patient who's borderline, say maybe 8 gram% can do with a regional anesthesia also.
Yes.
We just have one question. Is chest X-ray advisable or avoided during pregnancy because of fetal exposure?
Okay, you want me to answer that, Neha?
It should be preferably avoided. Yes, as a protocol.
We avoid chest
Although
X-ray
if
in
needed,
the first
one go for
trimester.
it because third trimester, a patient can be exposed. There's no risk of any teratogenesis as such.
Yes, but we have always keep in mind the risk-benefit ratio of everything that we do for the patient. Okay, so if the chest X-ray is going to be beneficial to the patient, it's going to give you a very important information that is going to affect the patient's morbidity, it is going to affect your anesthetic management, then you can get it in the third trimester with an abdominal shield. But in present situation, I don't actually see any such situation where a chest X-ray is kind of, the investigation that has to be done for a patient for us to decide about anesthesia or any of the management strategies.
Yes, ma'am.
Anything else?
No more questions.
Okay. Thank you, ma'am. Thank you,
Thank
Dr.
you. Thank you so much, Neha and Kartika. Thank you, Dr. Nathan.
Thank you, ma'am. Thank you for your valuable time and contribution. And thank you, Dr. Neha, for beautifully summarizing the whole topic and the essence of it.
अभी आ रहा है ठीक चलो पकड़ लिया होगा तो बता दीजिए हेलो
So welcome back. We'll move on to the next session. And I would like to invite the chairperson for the next session. We have Dr. Sanjay Agarwal. Sir is professor and the head of department at AIIMS Rishikesh. Sir's area of special interest are airway management, neuroanesthesia, and neurocritical care. Sir has several publications to his credit in national and international journals with 2 chapters in books, and he is an AHA certified BLS and ACLS instructor, ATLS and Airway Foundation instructor too. Sir has been speaker in various national as well as SARC conferences. We welcome you, sir. I'll hand over the proceedings to you, sir.
Thank you very much, Nitin. And good morning to you all. And I welcome you all to this session on neuroaxial anesthesia. We have 2 lectures during this session. The first speaker is Dr. Tripad Bindra. She is professor at GMC Patiala with the major achievements of being an AHA and ACLS, BLS instructor, airway workshop instructor, member of ISA, RACP, ISCCM, Airway Management Foundation. She is a regular participant in various conferences and workshop as faculty. Established COVID ICU at GMC Patiala. She is an author to a number of publications in Index Medical Journal, and she has a special interest in obstetric anesthesia, pediatric anesthesia, airway management, and ACLS. And she will be talking about on the topic which is on the neuroaxial anesthesia. So I welcome Dr. Tripad Bindra.